And welcome back. Our first conversation this morning, as we mentioned prior to our commercial break, is a discussion with representatives from the Ministry of Health and Wellness as well as the National AIDS Commission as we discuss responding to HIV/AIDS, particularly what is known as the Pre-Exposure Prophylaxis Pilot Project in Belize. Big words, but we'll get a very clear explanation from these gentlemen we have with us. Joining us in studio this morning is the Executive Director of the National AIDS Commission, Enrique Romero. Good morning.
Good morning, Isani. Good morning, Marlene.
And the Deputy Director of Hospital Services and Allied Health, Dr. Francis Murray.
Morning.
Good morning. My first question, I guess, to be able to create a picture for people who are watching, we need to first of all know how many people are suffering with HIV/AIDS at this present moment in the country, and perhaps what is being done based on the data to be able to address any concerns coming out of new infections and the particular age range of persons affected.
Right. Thanks very much, Isani and Marlene. Thanks for the invitation. As usual, it's always a pleasure for us to be here to share as much information as best as we can with the public. Now, latest figures, 2020, we're looking at an estimated roughly about 5,000 persons estimated to be living with HIV and AIDS. Of that 5,000, roughly about 50% have been diagnosed and know their HIV status. We have about half of that 50%, another 50%, about 1,500 persons on treatment and retained in care. And then we have another 40% on viral load suppression, which is our ultimate goal. We want people to be virally suppressed so that they can no longer transmit the HIV infection. In terms of new infections, yearly we have about 200 new infections. And the age range, which is always troubling for us, it's 15 to 39, particularly 15 to 24. 15 to 29 age bracket is when you see a lot of new infections, which, like again, is troubling for us. And on an annual basis, we have about 100 persons dying from age-related deaths. So when you look at the raw numbers, 200 new infections and 100 dying, you can safely say, not necessarily for that particular year, but you can safely say that 50% of persons who are diagnosed with HIV will die as a result of age-related causes. No?
And they don't have to. I think that's the key message.
They don't have to.
Let me step back for a moment. You used a number. You said estimated 5,000, confirmed 2,500, 50%.
Right, more.
How is that estimate made if these persons have not been tested?
Yeah, we have various modalities, and through CDC or UNAIDS, there's a tool called Spectrum.
Yeah.
And that Spectrum, you put in the data that you have according to your new infections or your monthly infections and the age group. So that throws out there a figure that is what they call a potential, the potential number of cases that are in country.
Yeah.
The 2022 Spectrum, UNAIDS came back, and because of the number of deaths that were being reviewed, it fell down to approximately less than 4,000 cases. So there was a modification in the numbers. As he previously mentioned, yes, we were above in 2020, 2021, 5,400 persons were persons who you suspect are infected with HIV in the country.
Yeah.
So that figure was modified recently, over about 2 or 3 weeks ago, and it does tell you that there's a gap still in testing. So it's a figure that tells you potentially how much may be in the country using figures, that data, number of new infections, and stuff like that. So it's a tool that we use, not from in-country, but from Spectrum UNAIDS.
Now, I imagine COVID had quite an impact on testing for the country, because that's the key part. If I don't know I have HIV, I may be unknowingly spreading it to others, driving up the new infection rate. What were the numbers for infections that we saw over the first 2 years of the pandemic?
Clearly, the testing numbers, for example, within 2018, 2019, we were having above 225 cases per year, new infections, or positive cases. Because I can't tell you, I can't explain or define if it's a new infection or a recent infection because of the time frame.
Yeah.
Okay.
So you would have to have other type of studies, medical studies that tell you, look, this is a new infection. So we're telling you about what persons who tested reactive and who tested positive. So we were, for years, we were like 225, 250, 255. With the pandemic, it fell to 130, less than 150, which mark that we had approximately 20 to 25% of the tests done on a yearly basis fell. So we had gone to 40,000 plus tests in a year at the ministry and our public facilities, and with activities done with the National AIDS Commission and other partners. In 2020 and 2021, these tests fell down to approximately 30 to 32,000 tests.
Wow. Yeah.
So that's a
significant
big,
drop.
It's a big drop. We are back up to 130. I think the last figures was 182, 192 in 2021.
Yeah.
So the numbers fell at least by 25, 30%.
Where is it usually detected? I mean, well, how does someone usually find out they're HIV positive? Are they in a healthcare system, maybe going for a checkup? When does it normally happen?
Well, there's various scenarios that you can test. And we do a lot of testing, community outreach activities, and also within our facilities. But there is certainly what you call PITC, which is Provider-Initiated Testing and Counseling. And it's an opportunity which we still have not capitalized as an entire country response. Saying, for example, if you have a patient that comes into your emergency room, the nurse or the attending physician, one of the first tests that they need to ask for is an HIV test. And so we fail in asking that person to do an HIV test, or maybe that person tells us no, and we don't go back and try convincing that person. So you have a person at the emergency room, you have a person at the outpatient scenario, you have a patient within your maternity ward, within your pediatric ward, within your medical or surgical ward. These are all areas within a hospital setting that we should capitalize in doing an HIV test.
Because it's not mandatory, they have to agree.
That's right.
And that's the process called Provider-Initiated Testing and Counseling. I go out and I ask the question. And so that's a gap that we really need to strengthen.
What is the difference between perhaps the PITC approach versus making the testing part of standard operational procedure, so to speak, where if you're dealing with someone who comes in who is ill, perhaps displays certain symptoms, that you would, I won't say mandate, but it would be part of the overall process that you would test the individual?
Yeah. Certainly, there are certain protocols that need to be set in place, and also the revision of internal policies and laws, I would say. I mean, if you have a person that comes to your hospital setting and all signs and symptoms are indicative of this process, then you reach out. If you need to pursue a surgical process, because there were certain period of time in the country that physicians, as you rightfully had said, this is stigma and discrimination, would not operate a person without having an HIV test. And in certain countries, this is mandatory. You want me to do a surgical procedure, you need to have a HIV test. So part of that process is really strengthening that gap and asking for it, because you can always ask your patient for it. If he tells you no, then that's what you can also do that panel. A comprehensive panel that includes within your testing scenario, hepatitis B, hepatitis C, HIV test. If you consider that person, because of the way you ask the questions, the responses that you get, the risk that you mentally qualify, that person may be at risk of spreading or having a certain disease or other virus, not necessarily HIV.
The education is key in this, and I know we were chatting about that before we got started. Just, you know, what HIV and AIDS was in the early 80s versus what it is now, it's different. It's considered, I think, a chronic condition. And I'm amused because sometimes you're watching television and you see a prescription ad come up for HIV, and it really is a great way for you to be able to see that things have changed, that you can live with HIV and suppress the virus to the point where you may get a test and it may be negative. Not that you don't have it, but it may be, it won't be detectable. And that is the goal here. So how do we try to get people to understand that there are options if you do test positive for HIV? Because we talked about that 50% on medication.
As you said, Marlene, I think, and as we mentioned earlier, one of our biggest gaps has to do with that communication. And gap in the sense that, not in the sense of people not having the knowledge, because, knowledge, attitude, and practices, studies have been done in the past, and it shows that Belizeans, 95% of Belizeans know what HIV is, how you can get HIV, how it's transmitted. They know about condom usage and so forth. So it's transferring that knowledge into behavior change.
Yeah.
And that is the challenge, because we know it's no different from any chronic disease. Like you mentioned, diabetes, you're told stay away from the sugars. But the first thing you do is you drink a soda, you eat sugar things and so forth. So it's no different in HIV. The medication can help. If you take the medication as prescribed, you can live a longer, normal life. If you reach viral suppression, it's not transmissible. The famous U equals U, undetectable equals untransmissible. So we need to ensure that our communication campaign focuses on those messages of behavior change. It's moving from the knowledge base to actual behavior change. No?
What's the shortfall with why, based on what you know so far, why people who test positive don't go on medication?
Well, as far as we understand, and we have a basic concept of the different barriers that exist within our country. One is the highly publicized and internally felt and community-based stigma and discrimination. Because a person who's HIV positive has internal challenges to accessing treatment. We have a treatment available in country, it's free of cost. Maybe also the structural barriers that you work from 5 to 10 in the night, and you work from 8 to 5, and after 5 you need to travel, take a bus, go further. And the only time available you have is that period from 5 to 10 in the night. And our support system is not there. Some of our clinics don't open after that. Also the financial component. You lose your job, your families throw you out of the house. You don't have any monies to buy food. And so those are just a few scenarios that limit a person's access to treatment. Then the person comes to us and he's mentally not able or ready to start treatment. Because we've moved on from what we call diagnose is treat the same day. So we no longer have that ability to wait and wait and wait. But internally we offer the services. If you get diagnosed today, Monday at 10 o'clock in the morning, you can start treatment at 10:01 in the morning.
Yeah.
Once you have that ability and internal concept that you're trying to you've realized that I'm infected or I've been sick for a while, I can start taking medication. And as you rightly said, you start the medications. We've also moved from these high pill burden. And by high pill burden, we're saying when we started treating HIV patients in 2003, it was only 4 of us, medical officers here. Myself, Arriaga, Dr. Aken, and Dr. Osorio in the north. And we were using combinations that were like 6 to 12 pills a day. We've moved away from that and introduced single dose combinations.
Did not discourage perhaps a number of people who
Yeah, because there's a lot of side
I mean,
effects.
that's an entire regimen of tablets and what have you.
Yeah, and then the side effects, as you rightfully said. I mean,
And now it's one, just so people know.
We can use 2 pills a day.
Yeah.
And so we've gone a long way. And also reflecting the numbers that you were saying previously. A few years ago, we were at viral load suppression of 13% or even lower. Recently, with the transition, because we introduced new drugs into the country, the regimen, we revised our guidelines in 2021. We started transitioning persons to the newer regimens. And so we've gone up to 760 persons virally suppressed.
Yeah.
And 1,561 on medication. So we're somewhere at the 50%. There's much more work to go. We have almost transitioned up to 1,200 plus persons to the new drugs.
Okay.
So that's a big plus for the national HIV program. And we have viral load countrywide that can be accessed within our facilities.
And I want to touch on that, because when you look at it or you put it into perspective, Belize has the tools to be able to address the HIV situation. We have the medication for treatment available for free still.
Yes.
Okay. So you can stay on medication. There's testing available for free. And then there's what's called the viral load test. I test to see how much of the virus I have in my body. so I can know whether or not the medication is working on me or not. So we have all of these things available for free. How do we get to the point where the people who are HIV positive are diagnosed, and we start to look at reducing the number of new infections?
These are some of the gaps that were identified during an assessment that was done in 2020, a country-focused global fund assessment that was done in collaboration with the National Health Commission and the Ministry of Health, identifying the gaps. And coming out of these gaps, we had these interventions, such as the HIV self-testing, the pre-exposure prophylaxis, the provider-initiated testing and counseling, index notification, whereby you go in, you're asked to bring your partner along with you. And under the Global Fund grant that we're starting implemented this year, we have some activities that will assist us, hopefully will assist the program in getting some of these persons to come and get tested. We have peer navigators program, peer navigators whose role is to navigate persons from the most at-risk communities to come and get it tested, not only at the Ministry of Health facilities, but at civil society organizations such as the Belize Family Life Association and Go Hoven Belize in Belmopan. So we have other layers of support to recruit some of these persons from the most vulnerable communities to assist us in navigating these persons to get tested. No? So these are some of the initiatives that we're trying to implement under the new National Strategic Plan. No?
So let's challenge some of the common stigmas here up front. The primary mode of transmission is through unprotected sex, right? And the long time assumption is that it is only homosexual males who are most likely HIV positive. Let's talk about the realities here. What's the transmissions that we're seeing, the cause of transmissions, and the vulnerable populations? How do we define those?
Well, basically what we've seen is that over the years, the various studies that we've had in country have shown that the MSM population in the country has had, I think it was 13.8 or 13.9% of incidence within that key population, followed by the transgender population, which is another group, and then the heterosexual community. We've not been able to pinpoint exactly what's the number of cases in our, we call it female sex workers or female or male sex workers, if you want to call it as well, because it's quite, the definition is not what we think, and some of them, as you rightly said, freelance and don't classify themselves as a female commercial sex worker. So that by itself, what we are seeing is that the main, the higher number of infections are in the men who have sex with men, the transgender, and also the heterosexual community. And so, and Mr. Romero had alluded to the age group, which is your working population, your productive sector. And
I think, just the list that you've given, I think of all the taboos where people are saying, one, what is that? Two, it's not publicly discussed.
And Marlene, I just want to mention, it's based also on we were discussing just a while ago on the risk factors, no?
Yeah.
So persons that have multiple partners, for example, persons that are not using condom consistently and correctly, because that's another thing, using condom and using it correctly and consistently is another thing. When we were looking at our data a few years ago, you had about 67% of people in Belize using condom. And then you had a lower 40% of using condom correctly and consistently. Yeah. So it's based more on the risk factor, and those are two of the risk factors, multiple partners engaging in risky behaviors of not utilizing condoms. So that is what puts you in that.
And if you use that assessment for your risky behavior, imagine the population that is potentially exposed.
And we have a large number of young people, as Dr. Moore mentioned, 15 to 24, 15 to 29, young heterosexuals that, studies show they have multiple partners, so that's a high risk group, no?
We've done studies. We've done studies supported by ESCLAN, and also with funds from Gilead. There was a recent study we did in Dangria, in the heart of the capital of culture, or the culture capital, which did show that you have young persons who have teen pregnancy, having 3, 4, 5 sexual partners, not using any other form of protection, and are what we call substantially high risk. And so that, by definition, a substantial high risk person is what we intend to target with the PrEP process.
Yeah.
That's right.
So once you have that behavior, you know, you are having sex out there with having anal intercourse, vaginal intercourse with more than one partner, not sticking to any form of protection, that's by itself what is happening within the MSM community or other groups.
And I just want to mention that that is not part, but the big focus of the interventions, in that we don't want it to tailor it to a particular group, because it further stigmatizes. You're stigmatized because of HIV, and now you're further stigmatizing people because PrEP is for this particular group. HIV self-testing is only for this particular group. So the idea is that it's focused on the risky behaviors.
How do you create public awareness, perhaps via a campaign or what have you, without singling or without identifying specific groups that may be affected or at a higher risk of exposure?
We have been very active on our Facebook page in terms of trying to promote the information through support, technical assistance from the Pan-Caribbean Partnership Against HIV and AIDS, PANCAB, through their multi-country regional grant, which Belize is a beneficiary of that grant. You know, they did an assessment in the region, looked at messages, and they included these vulnerable populations in the messaging. So this information was provided to us, and we tailor it to our Belizean context. And this is the information that we're trying to put out there. And I'll just say one of the key messages that, for example, in terms of PrEP, pre-exposure prophylaxis, is not for everyone, but everyone should consider it. Right? So that's a key message, because it's not for everyone, but you should, based on your risk factors, sexual risk factors, you should be in a position to determine whether it's something for you.
So
and as you said, the factors that you're looking at is unprotected sex and multiple partners.
That's right.
That's often.
Whether the sex is vaginal or anal sex.
Yeah.
There's the concept of prophylaxis goes beyond, it's to prevent infection.
Yeah.
So when we've started the programs and we've been supported and using WHO guidelines, having support from PANCAP and looking at the literature out there and the experience that we've seen, is that, for example, the PMTCT program, the elimination of mother-to-child transmission, is a type of prophylaxis. Because we started in the country way back using what we call a CD4 value of less than 500. And that was putting the mother on treatment early to prevent that child from being born positive. So that was prophylaxis. We move on eventually. Listen, once you're pregnant, once you're diagnosed as positive, you stay on medications for the rest of your life, which is coming to what you call a chronic disease condition. And so that by itself move on from what was prophylaxis, preventing that baby to be from being infected, was a form of it. And we still continue that process, but keeping that person on medication. So preventing that infection is looking at your numbers. We can't shy away from what is a reality in our country and saying, yes, trying to be out there, not to discriminate, not to stigmatize, but to be inclusive of all persons who are living and infected with HIV. Because PrEP is not only for MSM in other areas. It's for MSM population, the transgender population, for the heterosexual community, or what we call to as sero-discordant couples.
What
because
is
the male
Cheating
might be
couples.
well, possibly.
No,
Like multiple partners.
That's a scenario as
couples
well.
where people have multiple partners,
That's
which,
right.
let's be real, it happens a lot in the country.
What basically defends is also that the man it could have been to that ultimate action, but one of the persons in the relationship is positive. So it's either male or the female. So because you may find families like that the female was infected from a previous relationship.
True.
She finds a new husband and he's not infected. But that scenario is also where you can use PrEP as well. But that comes with the additional package. And the additional package includes condom use of lubricant, use other forms of protecting yourself and protecting your family. And that's where the pill comes in. For that particular.
So let's dive into what PrEP does. This is, and correct me if I'm wrong, if I am somebody who engages in risky behavior, I don't continuously or consistently use condoms, I have multiple partners, and I take PrEP, I would be a good candidate for PrEP. What is it? A one-time use? Yeah.
The very first thing in order for you to be a candidate for PrEP is, and Dr. Moore will speak about the other requirements, is that you have to be HIV negative.
Okay.
Because as Doc said, prophylaxis prevention.
Yeah.
So if you're HIV positive, you're no longer a candidate for PrEP. That's why I said earlier, and I think you were going to ask a question to explain that, you know, it's not for everyone, but everyone should consider it. So based on your risky sexual behaviors, then it's something for you to consider, but may not necessarily be for you. So if you're HIV negative, as Doc mentioned, the serodiscordant couples, you're HIV negative, but your partner may be positive and you're engaging in unprotected sex with your partner, you may be a candidate for PrEP. You may want to consider talking to your healthcare provider to do the test and so forth to determine whether you can be on PrEP, no?
So you be negative first.
You have to be
That's
negative.
The
That's the very first thing. Negative.
And have risky, and engage in what is considered
right,
risky
the multiple
behavior.
partners, not using condom, and having an STI. That's a sign that, you know.
And having, well, there's various criteria, and let me just go back a couple of seconds. PMTCT, PrEP, PEP, which is post-exposure prophylaxis. So you have for me, I'm a physician working in a hospital. I get prick, and the person is positive. I take medication for a month. That's another prophylaxis.
Very common with rape victims as well too.
So that's what you call non-occupational prophylaxis.
The rape one.
That is another form of prophylaxis. Okay, so you have different concepts. Now going back to what are the criteria for or eligibility criteria for PrEP? Being more than 18 years old, having an HIV negative test, having that risky behavior, as you rightfully said, of all the different courses, being mentally prepared to use PrEP because you have this scenario. So you've had an STI, maybe 2 or 3 STIs in a year, or 1 STI, shows you high risky behavior. And also being committed to using PrEP. So there are various criteria, and we have to have there's various medical interventions that we need to do. But the basis of PrEP is to show that you're not infected, that you don't have an acute HIV infection, and keeping you uninfected. Meaning that you stay, during the course of that entire 6 months that you're in PrEP, you're always testing negative. So with the package that we need to give you, it's the tailored for this process right now that we're going through, is providing the lubricants, providing the condoms, providing all other tests. For example, we need to test you for hepatitis B once a year. We need to test for hepatitis C once a year. I need to do your kidney function twice a year. I need to do your syphilis and HIV test at least every 3 or 4 months. So you have to agree to those terms. And also the adherence counseling and the mental health consultations that you need to give you, because obviously if you come with an STI, obviously there's actions, there's activities that you're not protecting yourself, or that you're at a couple who is also high risk. So those are some of the scenarios that we need to look at. Going forward, then you have to decide who is the best candidate. The readiness, because you can say, okay, the MSM population, you have various scenarios. Do I take PrEP daily? Or do I go into what is called event-driven PrEP? Or do I go into from event-driven PrEP into, or someone who's on PEP but has all these actions, and like you said, the PEP is that person knows that he's out there, has had occasions in which the condom has ruptured or broken, has had occasional anal intercourse without protection, and that person one day missed by chance, and you have a 7 to 1 window period to treat him. But at the ending of the scenario of the month, when you talk to this person and he tells you, you know what, I have 3 or 4 sexual partners, I'm not using condoms, I'm not protecting myself out there, I go to bars every weekend and I just drink and I party and I may have sexual intercourse without protection, then that person who went from a PEP scenario can fall into a PrEP scenario. But we have to do it on a case-by-case scenario.
So based on your behaviors.
Yes.
Right.
So if I get exposed, that's one category, but if I probably knowingly will continue to expose myself,
That's right.
then I qualify for PrEP.
Then we make a decision on what we both make a decision on what's the best scenario for you.
And just to mention what I mentioned earlier, that pre-exposure prophylaxis is part of a comprehensive combination initiative, prevention initiative, in that in itself reduces HIV infections by 90%, 95%. However, it only protects you against HIV. So pregnancy and STIs, it's recommended that you continue using your condom along with the pre-exposure prophylaxis. So you get double protection, triple protection.
This is a pilot project, as we've identified at the very beginning of the discussion. But I'm thinking about what the reception for this would be, based on the fact that you're essentially requiring of me or requesting of me to share with you certain information that I may not necessarily be comfortable sharing with you. Funny, because perhaps as men, if we're having drinks, I could tell you the amount of partners that I have, and it's an open conversation in that particular setting. But to go before a doctor and say, well, look, you know what? This is my lifestyle. These are the decisions that I'm making, may not necessarily sit well with me divulging that.
And also, that comes with the monitoring of the process, because I have to ask you for your information, and I have to put it into our system, the Belize Health Information System, and with all its securities. So what we're asking is for those who qualify for it, be ready to be frank with us. I mean, we have to build a relationship. And I'll be honest, I don't know what the uptake will be. We can have 5 persons within the next 6 months, or we can have 10 persons or 100 persons. So the message is out there. I mean, we could have had put in $100,000 into a communication strategy that makes a bang, and we have these persons accessing our services. And which is a modality for us to decrease the infections in the community within this particular high-risk group. But the studies have also shown that this particular high-risk group, as we spoke, I think last time we were in February, March, January and February when we were here, is that the MSM community and the LGBT community are already having other relationships. So it goes beyond what we think.
And that's why I keep on, I think it's important we continuously reinforce the point that when you say MSM, you're not talking homosexuals.
That's right.
You're not talking people who may identify as gay. They engage there are men who have sex with men and may have a wife as well, or a girlfriend.
That's why we were focusing not more on the individual or the groups, but more on the risky behaviors. You know? The unprotected sex, multiple partners. That could be men with men. That could be men with women, heterosexual. So it's more on the risky behavior rather than on the.
Our guidelines also reflect what you're talking about, because we are cognizant that we have the MSM and is open there. We also have the person who doesn't classify himself as an MSM or what we refer to as a closeted, and that person can also access the services. The PrEP can be tailored to that person, because that person, as you rightfully said, he's out there drinking every weekend, goes home and does his thing wherever he wants to, but needs that added protection, because this scenario of having a condom burst or not using condoms, and his partner or partners may not know their status, or he doesn't know. So that person by itself comes into what you would call PrEP services. But your willingness, your concept that you are putting yourself at risk out there because you're going home to a wife is what you may need to be conscious of us and say, listen, talk to us. I'm sure that the services will be given, and we're not pushing anybody back, because right now we do have couples in Belize who are serodiscordant couples that are using medications. We also have persons from the MSM population who are getting medications from the U.S. and from families outside the U.S. So we're cognizant that it's already in the country, and maybe it has been there for a couple
people are
months.
already using it.
Yes.
How does it work though?
So what it does is it's the PrEP. It boosts up your immune system, so that if there's any process of infecting, the immune system is up, your effects up, so that the virus doesn't multiply or doesn't infect you as much as possible. But it doesn't function on its own. it comes with the package. You have to use the additional condoms, they're decreasing that risky behavior.
Okay.
So
And the pilot project you're saying is for 6 months. Is this basically, explain to us why such a short time?
we're actually behind time.
Yeah.
I mean, we've been trying to do various modalities in the concept. In the country, we started with self-testing, piloting self-testing, which falls into this concept. An MSM person can access self-testing, and if that person is reactive or has a positive test, he can further access us for us to do further testing. We're trying to align many things at the same time.
Yeah. So self-testing means you swab yourself.
You swab yourself,
Yeah.
you test yourself, and it's a form of protecting yourself and knowing that whatever mechanisms, whatever process you're using, you're actually staying safe.
Yeah.
And which you can also give your partner, say, listen,
That's right.
Yeah.
you're out there, I am sure you have more than one partner, you can
Yeah.
do your self-testing.
Yeah.
So it's various modalities that we are trying to implement at the same time. And like I said, the guidelines, we started with the guidelines in 2019 from my desk, and it's obviously been 2020, 2021, a bit much more work.
Yeah.
And so we have, it's finalized, which we're going to printing, but we've done training. We've sensitized our physicians and healthcare and nurses. As of 2019, we started the sensitization because this was in the pipeline already.
Yeah.
So it's not something that we decided on
That's right.
January 1st, 2022, we're going to do this. No,
Yeah.
it's been there already on the ground.
Yeah. But you're calling it a pilot. Is this basically to see, I'm imagining it's a hefty investment, the purchasing of the medication. Are we going to monitor the uptake, whether people will voluntarily decide to take PrEP and see how that goes from there? Is that what we're doing?
Well, that is the plan in terms of, and just to mention, Doug mentioned we're behind. Like I said, as part of the multi-country regional grant that we're a beneficiary of, Belize, along with other countries I mentioned, Suriname, Antigua, and Barbuda, we're also in the piloting phase of pre-exposure prophylaxis. In February, we had training that was done with through PAHO with our healthcare practitioners and civil society on the whole PrEP, looking at the forms, screening, and so forth. So that is the idea for us to pilot this for the next 6 months and look at the uptake. We have to monitor the intervention to determine what is the uptake. Currently, the pilot will be Matron Roberts Polyclinic in Belize City, Belize Family Life Association in Belize City, but we are looking also at BFLA clinics in Orange Walk and Dangriga. And again, even though you mentioned this for a short period, there's nothing that can prohibit us from after the 6 months to maybe extend that pilot, maybe look at piloting maybe in other areas before we actually go into the full rolling out or phased rollout of PrEP in the country.
What's your target?
But
How many people would you like to
we
get
are
on PrEP?
prepared as a Ministry of Health to continue. This is just because of the PAHO scenario, the PANCAP scenario, this 6 months period. But preparation from our desk is there for us to continue beyond. So monitoring the numbers, as you rightfully said, getting those, for example, in Belize City, we may have a larger access, and I'm hoping that we do. San Pedro, where they have the higher risk groups in Orange Walk, because I'm not, and Placencia, we have these touristic scenarios, because I'm not sure in PG it's the same concept, or in Corozal, but we are prepared to go beyond 2022 in offering the services.
So this daily regimen, it's taken for how long?
Well, there's two scenarios, and there's, for example, the PrEP per se, which is daily, and we're you come in, we do your HIV test, you do your syphilis test, you do your hepatitis B test, hepatitis C test, the vaccine. If you don't have, we're also, the Ministry of Health is also prepared or has passed on the words to the BFLA and to the CO hub where these persons will be acting serve to give you the hepatitis B vaccine as well. We're going. It's for 28 days, and you can stay 3 months, 6 months on it, all depending on your
risky behavior.
Okay.
Yeah, and that's one form. The other form is the person who says, listen, I don't have much sexual encounters with my partner, and I do it once a week or twice a week. and it's only on weekends. So that person can take what you call event-driven PrEP. So that person takes 2 Friday morning because he knows he's planning and that he has an appointment at 3 o'clock in the evening. And then the Saturday takes another one, and Sunday takes another one, and that's it. And he goes back and sees his partner maybe 3 months down the road.
Okay.
So that's another modality. But that person who's on the 28-day PrEP can also stop. There's a certain period of time, let's say up to 7 days, that you can take the medication and then just stop. And goes back to the concept. Substantial risk and risky behavior, you start back on it again.
And the effectiveness of the PrEP, it's 92%, is that what I read?
Over 90% effective in reducing the HIV infection. And if used in combination with the other prevention methods such as condom, takes it to about 98, 99%. But I just want to mention on one thing that Dr. Morris said, and we have to be careful with our messaging, the event-driven, as the name indicates, for a particular event. So we don't want to have people feel that, okay, this is a substitute for not using a condom. So I'm going, I have my things set up for tonight, so I'll take my PrEP and I'll just do my thing without the condom. That is not the idea. Yeah, so we have to be careful with the messaging, that it's in combination with other preventative measures. And in the response, like I said, there are several things that we're putting in place to assist us in getting this done. We have the adherent counselors, we have the peer navigators, social workers, index partnering, which Dr. Moore mentioned. You go in for services and the doctor, nurse would ask you, well, can you bring your partner along to do an HIV test as well? That's part of capturing and recruiting persons to do an HIV test. That's the only way we can get it done.
All right, so if somebody's watching and thinking, I may be a candidate or I'm interested, where do they go, or who do they call? Do they have to come to one of the clinics you mentioned?
That's right. Matron Roberts Polyclinic, Belize Family Life Association. I think we have been distributing some flyers. It's on our Facebook page. The number's there to call, and we go from there.
All right. And in the meantime, I know you have Regional Testing Day coming up, so people can get tested again.
Right. That is June 24th in collaboration with the Ministry of Health. We are doing that countrywide, Belize, PG, San Pedro as well. So come out, get tested. You also get the opportunity to win a few nice prizes, get some tokens and so forth. No?
All right. Well, thank you very much for coming in. Anything else you'd like to say before we close?
From my end, just to thank you all once again for the invitation. Like I said, we have a new strategic plan, a new grant. There are new activities, innovative activities that are part of all addressing the issues of getting people tested, people on treatment, viral suppression. So all our work is focused on that continuum of care cascade.
And if you fall in this category, feel free to contact us. I mean, I'm sure that we have to continue building partnerships, building a better rapport with our population, with our clients, with our patients. And the only way we can have an impact and have this, whatever pilot project you consider, for me it's not a pilot project. I would have wanted this to start a few years ago and continue.
Yeah.
But nonetheless, the services will be there going forward.
That's right.
All right.
All right, well, thank you guys for having joined us this morning, and we look forward to hearing what comes out of the pilot project down the road. All right, so we're going to take a commercial break, and when we return, we're going to talk about Full Circle, the recycling of plastics. Stay tuned.